Hello everyone, welcome to today's episode of the Differential podcast. This is the fourth episode and today we are going to talk about immunodeficiencies. And it's really a very tricky topic because the set of labs and also some clues in the type of infections that patients will have and also the timeline, when do they present, all of these could interplay and give you a certain diagnosis instead of the other. So, let's say that someone comes to you with recurrent respiratory infections, hospitalizations due to pneumonia, and maybe 2 episodes of otitis media within the past year. And they are 9-year-old. And then, obviously, they are underweight, they look lethargic at the moment, and they are febrile because they have an active infection. And you look at the labs, and all of the immunoglobulins are at a low level. And this patient is 9-year-old. All of these recurrent infections are within the past 2 years, according to his mother. Now, another patient, he is 9 months old. He has literally the same history, similar infection profile. It started around 5 months of age. He is now 9, and his labs show low immunoglobulins, all of them. So IgG, IgA, and IgM. Your diagnosis is going to be different in these 2 patients, although they share the labs and they share the types of infections mentioned in the question. The one who's 9-year-old and his manifestations, infections, his deficiency manifested within the past 2 years, this is going to be common variable immunodeficiency. While the one whose infections began around 5, 4, 6 months, just around the time that maternal immunoglobulins started to fade from his system, this is going to be X-linked agammaglobulinemia or Bruton's agammaglobulinemia. And usually those are boys because it's X-linked, so rarely you will see a female with this condition. So you can see the age of presentation is different. Usually for common variable immunodeficiency, it will be someone who's a child, meaning school age or adolescent or even young adult at the moment where the infections begin. While X-linked will definitely present during infancy, and common variable will never present during infancy. So this is a very clear distinction that could be made here. Now let's say someone who is 2 months old and he presents with all of these sorts of infections, and he has an oral thrush as well, and all of the immunoglobulins are low, and that's it. They don't give you further data. Now, this is severe combined immunodeficiency. What's the reason that makes me think this is severe combined immunodeficiency? Again, the age of presentation. Despite the presence of maternal antibodies, the disease presents very early, and the oral thrush. So typically, when there is T-cell involvement, you will see non-invasive fungal infections, like an oral thrush, oral candidiasis. Okay, while with B-cell diseases like selective IgA deficiency, common variable immunodeficiency, X-linked agammaglobulinemia, you are not going to see fungal infections. Alright, so that's it for X-linked agammaglobulinemia, severe combined immunodeficiency, common variable immunodeficiency. Now there's a condition that's very closely similar to severe combined immunodeficiency. Let's say that this condition and severe combined immunodeficiency are in the choices. And I give you someone who's a 3-month-old, recurrent infections, oral thrush, he is failing to thrive, he has chronic diarrhea. All of these are manifestations of reduced immunity and the chronic infections. And this guy, let's say he has a chest x-ray that shows an absent thymus, which could be seen in both conditions, severe combined and the X condition I want you to guess. And he also has truncus arteriosus. So he's cyanotic, obviously. So what's the diagnosis here? This is DiGeorge syndrome, or DiGeorge syndrome, which is due to the deletion in chromosome number 22. So as you can see, it's going to be really very similar. It will affect T-cell function, and whenever T-cell is affected, as in severe combined immunodeficiency and DiGeorge, you are going to have B-cell function being affected and the low immunoglobulin profile across all immunoglobulins. Alright? So that's how you differentiate them. You will have extra features with DiGeorge. Okay. So just to summarize some of what we have said so far. So for common variable immunodeficiency, if they give you the flow cytometry, which I didn't mention because it can be differentiating, in common variable immunodeficiency, T cell and B cell count are going to be normal. All immunoglobulins will be low. In X-linked agammaglobulinemia, T cell count will be normal, B is low, all immunoglobulins are low. And then the worst of all, severe combined immunodeficiency, B and T cells are going to be low or absent, and immunoglobulins are going to be low across all of them. There is nothing up and the other is down. All of them are down. Alright, so I hope that now we can differentiate these three conditions. Now let's say some kid comes and he's 14-year-old and he has chronic diarrhea. He goes camping and he has this diarrhea now for 2 years since he camped. It's not clearing. He was treated for it and it recurred. And maybe they show you a stool microscopy. You can see a heart-shaped microbe, really good looking. That's giardiasis, right? And it's a foul-smelling watery diarrhea. Now, this same guy also have recurrent mucosal infections. So GI, as in giardia, and also respiratory and sinus and so on. And this has been going on for multiple years, let's say. He has atopy as well, so there is eczema. And now they show you his immunoglobulin profile and only IgA is reduced. So this is selective IgA deficiency. Okay, let's make it tougher. And I know we're already talking about selective IgA, so let's talk about two tricks that come with it. So some people may not know this. When you have selective IgA deficiency, you might develop antibodies of other forms. So let's say IgG, but against IgA antibody. So I don't have it. It's a foreign antigen for my body because I have IgA deficiency. So IgA is a foreign antigen. So let's think of it this way. So it's a foreign antigen. You might develop antibodies protecting you against it. So you become anemic and someone gives you a blood transfusion that by default will contain some IgA antibodies from the donor. You will attack it and you will develop anaphylaxis. So that's one thing that could happen. So anaphylaxis after blood transfusions raises suspicion of selective IgA deficiency, even if the individual was asymptomatic without a clear history of recurrent infections, because it doesn't necessarily have to have that recurrent history of infections. Many people have selective IgA deficiency and are asymptomatic. Another trick that comes with it is someone who has foul-smelling diarrhea at the age of 14. He's anemic. He has low vitamin D. He is not gaining weight. He always has diarrhea, specifically when eating bread, rice, things that contain gluten. Alright? So this makes you suspect celiac disease. However, his antibody workup, the IgA antitransglutaminase, is negative. Why? Because he has selective IgA deficiency. So what's your best next step? You don't go for colonoscopy, that's invasive, or endoscopy, upper endoscopy. You don't go for that. You go for IgG antibody. So you test for the IgG instead of the IgA. All right. So that's it about selective IgA deficiency. Now, other things that are specific for a single immunoglobulin, we have two hyper syndromes. All right. And I will let you guess which is which. So let's say that someone comes with an infection. All right. And this time his infection is, let's see. Let's make this one a bit tough. So let's say someone comes to us with an infection, and his infection is pneumonia, and he has recurrent ear infections and pneumonia. Despite frequent antibiotic courses, his infections keep on returning. He takes vaccinations, but they are not effective, so he is not developing sufficient antibody response to his vaccinations. Okay. Now, this patient appears tired, he's pale, he has enlarged cervical lymph nodes, he is infected, right? And you do an immunoglobulin profile, and there is only one immunoglobulin that's increased. What is this immunoglobulin going to be? I know that I'm not, this is guessing now, but just because someone has recurrent infections, and that's set in the history, and they tell you one antibody is up, this is IgM, and this is hyper IgM syndrome. Because when it's the other one, which is hyper IgE, aka Job syndrome, you will have extra features other than the immunodeficiency. So that's how you memorize them and tell them apart. In hyper IgE, you will have retained teeth, you will have cold abscesses, you will have coarse facial features. So there is these extra symptoms. Now the cause for each, for hyper IgM, it's going to be impaired class switching. So usually when we develop an infection, the first antibody our body makes is IgM. And then we start to develop specialized responses with IgG and so on and so forth. So in this case, you are not developing because the mechanism of isotype switching, changing the type of antibody, is impaired. So you have a lot of IgM, but you are not converting to other types. While when we are talking about hyper IgE, the problem is going to be different. And it's going to be related to STAT3 gene and Th17, T helper 17 cell dysfunction. So it's a bit different players and mediators when it comes to hyper IgE. The specific protein impacted in hyper IgM is the CD40 ligand. And the interaction between CD40 and CD40 ligand is critical for class switching. Okay, let's say someone is 5-year-old and they come with recurrent Neisseria infections. Now they have positive meningitis signs, symptoms, headache, photophobia, vomiting, neck rigidity, they have petechia, they are hypotensive. It's recurrent, and so on and so forth. That's complement deficiency, specifically membrane attack complex, which is C5 to C9. All right. Now someone else has recurrent infections, and now he has a skin infection, so cellulitis. And you look at the CBC, it shows a lot of neutrophils. It's 50,000 neutrophils and 70,000 WBCs. 50 of these are neutrophils. And let's say he develops some abscess subcutaneously, and we take that for microscopy and we see bacteria, we see maybe macrophages, but we don't see any neutrophils. This is a leukocyte adhesion deficiency. These patients will have a neutrophilic response, but the neutrophils will not be able to migrate from the blood vessels into the infected tissue to clear the bacteria. So they have these abscesses that do not have neutrophils within them, and during infections they will have exacerbated neutrophilia. Not the usual WBC reaching 14, 16, 17, 20. It's going to be way more than that, and mainly composed of neutrophils. So the mechanism here is impaired neutrophil chemotaxis, and some proteins that are commonly impacted are called integrins. All right? Now, I want to go back to common variable and common variable and X-linked agammaglobulinemia, because I'm talking about the mechanisms of these illnesses, which commonly are asked about in exams. So in X-linked agammaglobulinemia, the issue is in B-cell maturation. That's in X-linked agammaglobulinemia. While in common variable, it's B-cell differentiation. So in common variable, it's B-cell differentiation, and in X-linked, it's B-cell maturation. How is that making a difference in the flow cytometry? In common variable immunodeficiency, you will have normal T count. Again, this is not a B-cell disorder. It's not severe combined. So T count is normal. B count is also normal with common variable. The decreased thing, which we don't test for typically in flow cytometry, are plasma cells. So when we say in common variable immunodeficiency, there is impaired B-cell differentiation, that means B cells are not becoming plasma cells. While in X-linked agammaglobulinemia or Pretton's agammaglobulinemia, there is a problem with B-cell maturation, which means that B lymphoblasts in the bone marrow are not becoming these mature adult B cells that circulate and we detect in our flow cytometry. So T cell is normal, B cell is low, and obviously as a result plasma cells are low. In severe combined immunodeficiency, T cell formation is abnormal. So low T cells, they influence B cell maturation and development. So low B cells and low plasma cells and all immunoglobulins are low. Alright. So that's how you differentiate them. That's how you learn about their pathophysiology. Now someone else comes with a multitude of infections, and his immunoglobulin profile is absolutely normal. His WBC count is absolutely normal. It's just recurrent infections. And then they seem to mention specific pathogens. So he had a skin abscess with Staphylococcus aureus. And he had a pneumonia with whatever that bacteria is that commonly shows up with cystic fibrosis, Burkholderia, I don't know if I'm saying it right, Cepacia, and maybe some urine infection with Serratia, SERRATIA. So these bacteria you are hearing about, maybe some Aspergillus, maybe some invasive candidal infection. So there is a group of bacteria that are, and fungi that are catalase positive. If you see that pattern, multiple of these, this tells you this is a chronic granulomatous disease, which happens due to NADPH oxidase deficiency. NADPH oxidase is necessary for respiratory burst. It's going to be helping our phagolysosomes, these cells that phagocyte, they eat bacteria and then destroy it within. Once they eat bacteria, they don't have the enzymes to create radicals, to create weapons, to create pumps that kill bacteria. So catalase positive bacteria will be able to escape another mechanism alternative to NADPH oxidase, so they will survive. So the brief story here, if you see these bacteria, these fungi, a combination of them, think of a chronic granulomatous disease, think of NADPH oxidase deficiency. Now, a point that came to my mind, let's say that someone comes and he have headache, confusion, these symptoms are chronic, they wane and become severe again, and he has also recurrent respiratory infections. He's an infant or maybe 2-year-old, and this has been going on since infancy. But he has chronic enteroviral meningitis. So most commonly you link viral and fungi with T cells and link bacterial with B cells. And this is valid thinking. However, when you hear chronic enteroviral meningitis, this happens to be very associated with X-linked agammaglobulinemia. So that's the answer there. Okay? Alright, so what else we didn't discuss? Now someone comes with a chronic granulomatous disease, they ask you what's your best next step, or what's the diagnostic study you are going to do. We said immunoglobulins are normal, flow cytometry is normal. So you are really left, and also CBC will be normal. So you need to do a special study, which is the nitro-blue tetrazolium. This is the study of choice that you are going to do. Alright. So, let's say someone comes with a cleft palate and they also have, let's say he's a newborn, or let's say he's 2 months old. He has a cleft palate and he is following up with the plastic surgery and the speech therapy and whatsoever. So they plan when to surgically intervene with the cleft palate. And once during a hospital visit, also he has been having recurrent respiratory infections, he is not gaining weight, he has diarrhea on and off, and his mother is complaining of that. And during the clinic visit, when his blood pressure was being measured by the nurse, he starts to contract his hand. He starts to hold and then release, hold and then release. He has this contraction going on with his hand. What should you think here? This is DiGeorge. So cleft palate is one of the manifestations. Why he is having this carbopedal spasm? It's the hypocalcemia. Because in DiGeorge you have agenesis, meaning not making of both the parathyroid glands, so parathyroid hormone is lost, so hypocalcemia, and also of the thymus, so T cells are lost. Okay, fantastic. Let's see where we're going to go now. Okay, I have a few more. So, someone comes with recurrent infections and eczema. We have seen this pattern before, and you will go and jump from your seat. It's selective IgA deficiency. Do not get excited. Eczema is very non-specific when it comes to immunodeficiencies. Do not rely on it. You will see it with hyper IgE, Job syndrome, the one with the retained teeth, the coarse facial features. Another manifestation there is eczema. You will see it with selective IgA deficiency, and you could see it as well with Wiskott-Aldrich syndrome, which have a triad of recurrent infections, Microthrombocytopenia, so micro meaning small platelets on smear, thrombocytopenia, so low platelet count, so petechia could be seen. Recurrent infections and eczema, so eczema is non-specific, okay? Alright, so that's Wiskott-Aldrich. Someone has whatever recurrent infection. He has diffuse hypopigmentation, meaning albinism, okay? And they tell you that the smear, or they give you a picture of a smear, and you see large granules within the cytoplasm of multi-lobed or multinuclear cells, polymorphonuclear cells. These are neutrophils, and you see large granules within them. This is pathognomic for celiac Higashi syndrome. So even if the presentation was someone who has two heads, he has cleft palate, cleft lip, and hypospadias, whatever it is, forget about infections. He has the strongest immunity in the world. They show you large granules within neutrophils. You are choosing celiac Higashi because this is pathognomic. Alright? These are the immunodeficiencies that I had in mind. I think this is the majority, and this covers the important ones. So we are going to finish with these. I hope you like this episode. I'm trying to use more of a question-based style to make it fun, and I hope that you have been taking notes and you find this helpful. See you in the next episode. Bye bye.